Okay, so thank you very much for the kind invitation. I'm Mohammed Shelan. I'm Assistant Professor of Radiation Oncology in Switzerland. It's really a pleasure to talk to you today. And yeah, due to some logistics, I cannot make it in Oman, but inshallah next time. My topic today will be the treatment options for localized prostate cancer. I prepared a very brief presentation to allow time for questions if needed. And also, I will give you a short overview about all the options, but the main course of the topic will be covered by Dr. Nadim and Dr. John. So those are my disclosures, and the content of my talk will be divided into three parts. The first part is the active surveillance part, and the second part is the focal treatments, and then the third part will be the definitive treatments. Just as a warm-up, we know that prostate is a 20-gram organ. It looks like a chestnut, and it begins to grow by the age of 40, and after that age, we start to have problems. We also know that prostate cancer ranks as the second most frequently diagnosed cancer among men. We also, through the PSA screening and the greater awareness to prostate cancer, we have a large proportion of patients being diagnosed in the organ confined disease. And for those organs confined disease setting, we have a lot of options. Just imagine a prostate cancer patient being diagnosed in the localized situation. We could do all the following. We have the watchful waiting or the active surveillance. We have the focal therapies. We have the radical prostatectomy and external beam radiation. This could be in combination with hormonal treatment or without hormonal treatment. We have also the proton treatment, and we have the core of the course today, the brachytherapy. That can be LDR, that can be HDR, that can be a lonely treatment, or it can be also combined with external beam radiation or even hormone treatment. And as you see, there's a lot of ways to go. And unfortunately, we have a very basic standard clinical pathological factors for prostate cancer that determine the treatment options. That means we don't have a super individualization of patient is not available in this case. We have the standard risk classification, the low risk, the intermediate risk, and the high risk, and you have a lot of options for every patient. That means for every patient, the treatment decision should be individualized based on the clinical pathological factor, besides what the patient wishes or what the patient wants, and also what's available in the center. So the first thing would be active surveillance. For the active surveillance, the goal is to delay the potential curative intention if needed without missing a window for a cure. This is compared to the watchful waiting. For the watchful waiting, you're not doing anything to the patient. You're waiting that the patient get metastatic, and then you offer a palliative treatment. But if you're doing active surveillance, that means you want to postpone the treatment without missing the window of cureness. The active surveillance is the very good option for patients with very low risk, for low risk, and some favorable intermediate risk patients. And for the active surveillance, there's a lot of protocols and published in the literature, and they are very heterogeneous. Every own department has own scheme for the active surveillance. But the main course of the active surveillance will be the PSA monitoring, and then the periodic digital rectal examination, and the MRI and the biopsy. The American Urology Association and ASTRO guidelines recommend that the surveillance prostate biopsy is done 1 to 3 years, and they should be individualized based on the risk of progression. The one important component of the active surveillance is the multi-parametric MRI, and we know it aids to do a sort of risk assessment in patient active surveillance, and the American Urology Association and ASTRO guidelines recommend that MRI should be done before the conformity biopsy, but it does not replace the biopsy because there's not sufficient sensitivity to histological progression. And for the main question also for active surveillance that being asked by many patients, what would be the reasons to convert the patient from active surveillance strategy to an active treatment. If the patient has a Gleason pattern 4 or 5, it's a clear indication. If the patient has more than 2 biopsy cores are involved, or 50% of a biopsy core is involved. One other indication that we also face in the clinical routine, patients who feel anxious, who wants to go for an active treatment and does not want to do the periodic examination in the frame of the active surveillance, is also a good indication to start an active treatment. One evolving role for the biomarkers in the active surveillance, we have a lot of biomarkers that we can use. The BRCA2 gene, we know that the patients who are BRCA2 gene mutated are having worse prognosis than the non-mutated patients. We have the oncotype DX and we have the pro-layers cell cycle progression. They are only examples, but there's also more markers available in the market. The main conclusion that those markers are being used mainly for research purposes and being offered in the frame of trials, but not recommended for routine use and should not be used for patients who have a clear indication for active surveillance or an immediate active treatment. The second part of my talk is about the focal therapies. And the focal therapies, they are very various. We have a lot in the market for to offer as a focal therapies. I like the division to divide them non-radio-oncological, like the cryotherapy, like the HIFO, like the electroporation, and the radio-oncological, like the focal brachytherapy, which can be also covered today in the course, and focal SPRT. For the focal SPRT, the evidence is really very minimal, maybe 2 or 3 literature cases in very limited, well-selected patients, so it's never a standard of care. So for the focal therapy, the rationale behind that we have a very good imaging and staging using the multiparametric MRI and the target biopsy. And the idea behind, if you could target the index lesion that can prevent tumor growth as well as decrease the risk of metastasis. And when you're treating a small part of the prostate or even a lobe of the prostate, you can minimally affect the bladder and sexual function, which is the goal of most, some patients. The results for the focal treatments are various because there is a lot of treatments, but I selected 2 recent publications, one from last year from the University of Heidelberg. In a frame of phase 2 trial, the colleagues did a unilateral localized prostate cancer treatment using the HIFO, and as you see, the biochemical rate progression after 1 year is 38%. And this is in patients with low risk and favorable intermediate risk. After 1 year, about 40% of the patients have biochemical failure. And this is a large systematic review on the focal therapies published in the European Urology last year, about 72 studies where the colleagues addressed the role of focal treatments. And as you see, the colleagues state that the focal treatment cannot be considered as standard as the evidence for the focal treatment is not high quality evidence. And this leads to the next slide where we see that the European Association of Urology combined with the ESTRO and a lot of societies stated that the focal treatment could be an option away from surgery, away from radiotherapy, but it should be only offered using in a frame of clinical trials or prospective registries. That means it should not be the standard of care in this case. So the last part of my talk, would be the definitive treatment. As you know, there are 2 gold standards for the localized prostate cancer, the prostatectomy and radiotherapy. And for the prostatectomy, we do a removal of the prostate, seminal vesicle, and the draining lymph nodes when the risk indicates removal. And we know that prostatectomy can be done open or minimal. And now we have the evolving role of the robotic surgeries. And we also know that centers who have high volume have more favorable outcomes than those with low volume centers. One good question about the radical prostatectomy is the pelvic lymphadenectomy, because it could have a prognostic role for the patient, and it could be limited lymphadenectomy or extended lymphadenectomy based on the number of the lymph node dissected. And As far as I know, there is no prospective studies have demonstrated the optimal anatomical limits of pelvic lymphadenectomy in prostate cancer, but we have some retrospective data from Johns Hopkins where extended lymphadenectomy patients had a better outcome after 5 years compared to who underwent a limited lymphadenectomy. But this is not a randomized trial, and it's also an area of research for the urologists. To the radiation, I mean, we all know the radiation techniques, what we're using now for the prostate. We have the 3D and the IMRT and the VMAT, and a lot of things we're using nowadays, but the IMRT remains the standard mode of treatment delivery in this case. And then we come to the outcomes of such treatment. We have a non-endless debate, which would be the optimal strategy to treat patients with localized prostate cancer. We have a young, sporty, fit patient will automatically undergo prostatectomy, and which patient will go will undergo radiotherapy. Such patients who are older in age, having a lot of comorbidities, which might affect the expected life expectancy. We have been in this debate for years until the year 2016, where the colleagues from UK, the group from Hamdi et al., published the 10 years outcome of the PROTECT trial comparing monitoring, surgery, or radiotherapy for localized prostate cancer. And as you see, for the prostate cancer specific survival, there were no differences between the three groups. If the patient who did not get an active treatment, if we check the freedom from disease progression, we will see that the patient who underwent radiotherapy and surgery had better outcome compared to the patient who got active surveillance or the active monitoring. But in all, we know that the mortality from prostate cancer is very limited. Like last year, the trial was updated and the colleagues published the 15 years outcome of the three treatment modalities. And as you see, if the curves looks like the same, the patients will rarely die from prostate cancer, but they may develop more metastasis if they do not undergo active treatment. And we know that due to this low rates of mortality due to prostate cancer, it's more the treatment choice could be mainly based on the toxicity and quality of life profiles of the treatment. If we check the quality of life for the PROTECT trial, we see that radiotherapy compared to surgery has a better outcome in the incontinence compared to the active surveillance. There's no big differences between the radiation and active surveillance. However, in the surgery group, up to 50 patients will still incontinent even after 6 months after the surgery, and this will recover after 6 years and will be only 17%. About the sexual function, which is the main object of a lot of patients, the 1 year intact sexual function in the surgery arm is only 12%, continues to improve to 17%. In the radiation arm, you see 22 patients will have intact sexual function improved to 27% after 6 years, and with the active surveillance arm, the patients still having intact sexual function. But if you compare the 6 years outcome between the radiation and the active surveillance, almost no differences between the radiation and the active surveillance. Of course, we know that patients treated 15 years ago being treated with old radiation technique, we have like 5.6% blood stools after 2 years compared to the surgery and compared to the active surveillance. But as you see, it's very old radiation plan where large portions of the rectum are in the target volume, in the high dose target volume, and this might be the reason for these blood stools. So if you check the NCCN guidelines, we have 3 fractionation schemes for prostate cancer treatment using external beam. We have the moderate hypofractionation delivering between 2.5 and 3 gray per fraction, and the conventional fractionation using 1.8 to 2 gray per fraction, and the ultra hypofractionation 6 gray and beyond. And as you see, the moderate hypofractionation is the most preferred scheme. based on the strong level 1 evidence delivered from the CHIP trial, from the PROPHET trial, from the RTOG trial, and from the Dutch hypo trial. And there's also an evolving rule for the SBRT in these patients. This is a large, I would say, a review where we included the prospective series with more than 3 years follow-up time who underwent stereotactic radiotherapy of the prostate. As you see, the patient got a dose between 33.5 to 40 gray and combined with ADT in most of the cases, and we have excellent outcomes in the low risk after 5 years or 7 years. And I would say for the high risk, it's not also that bad. And also the very acceptable late GI and GU toxicity. The prospective evidence for the SBRT in prostate cancer was generated mainly by the hypo-RTPC trial published in The Lancet 2019, randomizing patients between normofractionated radiation, 78 gray and 39 fraction, compared to SBRT 7x7, and it was done with 3 times a week. And as you see, between conventional fractionation and ultra-hyperfractionation, there is no differences on the failure-free survival and the overall survival. For the toxicities, the patient who underwent the conventional fractionation has less RTOG grade 2 or less GU toxicities, but the prevalence of the late RTOG toxicity still favors the conventional arm, but no differences on the GI toxicity over 5 years. The second large trial covering the ultra-hyperfractionation in localized prostate cancer is the PEACE-B trial, comparing the conventional fractionated radiation using 2 gray per fraction or moderate hyperfractionation in one arm, and the other arm was the ultra hyperfractionation using 5 fractions to a total dose of 36.25 in consecutive days. And it was a non-inferiority trial where about 60% got VMAT glands and 40% got CyberKnife treatment. And as you see, unlike the hypo-RT trial, there is no differences in the RTOG toxicities between the 2 arms. And actually, exactly the same for the 5 years outcome that was presented by Professor Nicholas van Ast in the ESTRO last year. We have an excellent biochemical control up to 5 years, 49.6 in the conventional arm and 95.8 in the SBRT arm. So one rising question is the SBRT versus radical prostatectomy. The PEACE-A trial was published in abstract form also last year, comparing the radical prostatectomy to the SBRT in 5 fractions. And as you see, this is the co-primary endpoint, which was for incontinence. We still see that up to 46% of the patient undergoing radical prostatectomy will have incontinence, compared to only 4.5% in the SBRT arm. So we can sum up and conclude that the SBRT in 5 fraction could be considered as a standard of care standard of treatment in low and intermediate risk prostate cancer. Just one slide to the ADT rule. For the low risk prostate cancer, there is no benefit, overall survival benefit over 15 years when we adding ADT to radiotherapy in the low risk prostate cancer. However, for intermediate risk, there's a lot of trial using the ADT, even the new generation ADTs, to escalate the treatment with radiation. And as you see, some studies could achieve an overall survival benefit using 6 months ADT. Now the standard of care in the intermediate risk prostate cancer is radiation plus 4 to 6 months ADT. So I come to the take-home message. I would say that active surveillance remains a valid option for low-risk prostate cancer. And I also can conclude that focal treatments are not yet standard, should be only performed in the frame of clinical trials. and should not be offered in the practice to every patient, only well-selected patient. And we can say that the level 1 evidence showing no significant survival differences between radical prostatectomy and radiotherapy exists. We have a favorable quality of life outcome using the radiation. And I would like to close my talk with this view. This is the city of Bern where I live, and I would like to welcome you to Bern anytime. Thank you so much.